الرحيم. برحب بحضراتكم في مراجعة الموديول بتاع الفيميل ايميجينج، وأكيد انتوا خلاص متعودين على طريقة المراجعة. فاحنا هنعمل نبريزنت الكيسز وحضراتكم هتجاوبوا عليها عن طريق الشات، وانا هكومنت على الإجابات ان شاء الله. And this is the first case of a female, 23 years old, and he is known to be HIV positive, presented by abdominal mass. And this is the MRI of her pelvis. Okay, and the answer is this germinoma. Actually, you may consider this because of two factors. Number one, the younger age of the patient. Number two, the bulky appearance of the mass. Then you can appreciate that two lesions can be solid and form huge masses in the pelvis, and these are this germinoma and the lymphoma. If you look carefully, then you see that the mass is bilateral, and there is involvement of both ovaries. The uterus is good, and then considering the patient history of HIV, then the possibility of lymphoma is a little bit more likely. But if you are confronted by a similar case and you don't have the history, then you can easily diagnose the possibility of this germinoma. Next case is a female, 22 years old, with a cystic lesion, as you can see, and this lesion was detected by ultrasound. Yes, and this is cystadenoma, and you should specify the mucinous type of cystadenoma, because the serous type of cystadenoma is a unilocular lesion, but the mucinous type is a multilocular lesion with internal septations, and you can many times you see different signal intensities of the components of the lesion. Next case is a female, 20 years old, presented by acute abdominal pain and rigidity. Simple ovarian cyst, does not contain septations. And this is the right answer, ruptured dermoid cyst. If you look carefully here and you see the criteria of a dermoid cyst, which is a cystic lesion containing fat, containing calcium, as well as some of the fluid densities. Whenever the presentation is acute, you think of rupture of this dermoid cyst, and this will irritate the peritoneum and will result in a lot of fluids in the peritoneal cavity. There may be some contrast enhancement of the peritoneal reflections, and sometimes you got fat fluid level inside the peritoneal cavity itself, and the answer is right. This is ruptured dermoid cyst or ruptured teratome. Next case is an MRI of the uterus. Actually, uterine fibroid will not show this signal intensity, But this is endometrial carcinoma as answered by Shaima. And this is endometrial carcinoma. It is a mass within the uterine cavity. It does not invade the uterine wall. And this is FIGO stage 1A, as you know. Then next case is an asymptomatic patient, 40 years old, with MRI of the uterine cervix, and this is the gross appearance of the cervix itself. Adenoma malignum is a huge number of cystic lesions in the cervix. There is offensive vaginal discharge, but this patient is totally asymptomatic, and the answer is Nepocian cysts. Yes, and this is Nepocian cysts, and the cysts can be many and can be sizable, but they are quite different from the adenoma malignum in the extent of the cystic lesions and also in the watery offensive vaginal discharge. And this is another example to emphasize that Nepocian cysts can be sizable, as you can see here. And they show that the criteria of the cystic lesion being of high signal in the T2 with no diffusion restriction and no post-contrast enhancement. This is a DEXA scan, and what do you think? This is osteoporosis or osteopenia? Yes, the answer is right. This is normal DEXA scan. And the DEXA scan, you just look for this black dot. If the dot is in the green field, the patient is normal. In the yellow field, this is osteopenia. In the orange field, this is osteoporosis. In the red field, this is a severe osteoporosis with high risk of fractures. Next is a female, 37 years old. She had hysterectomy and bilateral salpingio-oophorectomy for ovarian cancer, presented by elevation of the tumor markers. Yes, the answer is right, and this is local tumor recurrence with metastatic deposit in the spleen. And you should not see in the operative bed an irregular mass heterogeneously enhancing, inseparable from the bladder and the rectum. This represents local recurrence, and this is splenic deposit. Next case is a multiple woman presented by huge abdominopelvic mass associated with frequency of urine, abdominal distension, chronic pain, and she gave a history of regular menstrual cycle. Huge fibroid with degenerative changes. Yes, right. This is the right answer. This is cystic degeneration of a fibroid, a very huge fibroid uterus. And this is the suggested differential diagnosis by the literature. Primary uterine sarcoma is an invasive tumor that can invade the surroundings, including the skin. And primary left ovarian carcinoma, but here the tumor is originating from the uterus. Metastasis like Krokenberg tumor from gastrointestinal tract, but there is no history actually for primary malignancy, and this is a uterine lesion, not an ovarian lesion. Next case is a female patient, 54 years old, presented by abdominal pain and palpable pelvic mass. This is T2 axial, T2 coronal, and T1 post contrast with fat suppression. Liposarcoma and dermoid cysts. Okay, let's look to the lesion. There is this is an adnexal pathology because the uterus is okay. Then the lesion is of bright signal in the T1 in the T2 weighted images, and in the post contrast it showed marginal post contrast enhancement. And this is actually, you need the T1 before contrast to be sure that this lesion is of low signal in the T1, and this is tubo-ovarian abscess. The tubo-ovarian abscess has, according to the literature, a characteristic sign which is known as the beak sign. And this sign differentiates the tubo-ovarian abscesses from the pelvic abscesses. And here, the tubo-ovarian abscesses may be bilateral, as you all know, and they show marginal post-contrast enhancement, and they are of low signal in the T1, high signal in the T2, and they show restricted diffusion. This is a salpingogram, histosalpingography. Yes, and this is a simple case, bilateral hydrosalpinx. The tubes are markedly dilated with no peritoneal spill. Next case is a female 40 years old with known gastric cancer, lower abdominal pain, solid adnexal masses on ultrasound. Yes, and the answer is right. This is bilateral Krokenberg tumor or metastatic deposits in the ovaries. And this is a well-known lesion, especially in the presence of GIT malignancies. They can send transcoelomic metastatic deposits to the ovaries. Next case, and this case is related to the previous case of tube-ovarian abscesses. Here you can see bilateral abscesses in the pelvis with characteristic marginal enhancement, and you got some fluid signal in the pelvis. Then you are expected to see some of the complications of pelvic inflammatory disease. There may be obstruction of the ureters because of the intimate relation of the adnexal masses to the distal part of the ureter. There may be bowel obstruction due to adhesions in the small bowel in the pelvis. And you may got ovarian vein thrombosis because of the the ovaries are drained by the ovarian veins to the IVC, or on the left side to the left renal vein. Then you may see this marginally enhancing lesion along the course of the ovarian vein, which indicates thrombose. Then whenever you are confronted by a case of pelvic inflammatory disease or tubo-ovarian abscesses, look for these findings. Number one, ureteric obstruction. Number two, bowel obstruction. Number three, thrombosis of the ovarian veins. Of course, you got some ascites. Next case is a female patient, 20 years old. This is MRI T1 with fat sat, T2, and T1 post contrast with fat saturation. Yes, and this is a case of dermoid cyst. You see, this is fastest spin echo. I am sorry. This is fastest spin echo. The fat is bright. On the fat sat sequence, the fat is suppressed, and the lesion contains other soft tissues, very characteristic of mature cystic teratoma or ovarian dermoid cyst. Next case, and this is diffusion weighted images and ADC of the uterus. Yes, and this is endometrial carcinoma invading part of the myometrium, not the whole myometrium. And this is the way how to measure the myometrial invasion. You put a line corresponding to the normal site of the junctional zone or the normal site of the endometrium. Then you measure the thickness of the uterine wall and the thickness of the tumor. If the tumor invasion is more than 50% of the uterine wall, and this is stage A, B. But if it is less than 50%, then stage stage 1A. If it is less than 50%, stage 1B if it is more than 50%. Next case is also a female patient with gastric cancer, and this is the left ovary and the right ovary by ultrasound, and this is the left ovary by CT, and here is the right ovary by CT. Yes, the same. This is Krukenberg metastatic lesions or because of the gastric carcinoma. Next case is a hysterosalpingogram. Yeah, TB, salpingitis. You do not see the tubes. You may say that this is TB endometritis, but what is you looking at is a very irregular, reduced endometrial cavity, and this is due to the presence of intrauterine adhesions, and intrauterine adhesions are known as Asherman syndrome. It can be caused by previous infections, previous DNDC technique, or previous TB affection, and so on. Next is hysterosalpingogram. Is uterine adhesions, you are right. What do you think that these arrows pointing to? Okay, and this is actually the wall of the fallopian tube, and this is peritubal halo. It is known as peritubal halo, which indicates inflammation of the tube due to salpingitis, and salpingitis will result in edematous changes of the wall of the fallopian tube. Next case is a series of MRI, axial T2, sagittal T2, coronal T2 of a cervical cancer. And this is right. And cervical carcinoma, you know the staging of cervical cancer. I was presenting here by video, but it's okay. This is cervical cancer when and the size and parametrial invasion indicates the stage of carcinoma and also the extent of the tumor into the vagina. Next case is MRI. This is T2 and this is T1. This is T2 and also this is T2. And what do you think of this lesion? Hematocolpus, yes, hematocolpus, and you know this lesion is not an ovarian cyst or hemorrhagic cyst, for example, because of the deep extension into the pelvis, and the ovarian cyst or any adnexal lesion cannot go markedly downward in the pelvic cavity, and this is blood in the vagina, and it's known as hematocolpus. Next is a female patient, 31 years old, and presented by acute pelvic pain. Actually, I know that this is the difficult case, but you answered right. This is ectopic pregnancy, and here is the uterus, and this is the ovary with characteristic appearance, and you see what looks like a fetus, and this is the placenta, and it has no relation to the uterus, and this is ectopic pregnancy. Yes, and very good that you can clinch this case. Next case is a female patient, 33 years old, presented by left-sided pelvic pain. And torsion of the right ovary, and actually this is the urine bladder. This is the ovary on the left side, and I cannot see the ovary on the right side. And here are the vessels, and this is the lesion. Okay, I actually presented this case in order to let you know that not every mass in the pelvis of a female should be of gynecologic origin. That's to say, you can be confronted by masses that are not related to the uterus or the ovary. And the clue here is that you can see the normal ovary and you see another mass. And this mass is having what is known as the ball on a string sign. And here you can see that there is what looks like a ball, and this is the rope or the string sign, which is one of the characteristic findings of neurofibroma and schwannomas. Next case is CT of the pelvis, and we are asking about this lesion. This is the uterus, and this is the urinary bladder, of course. Okay, and yeah, one of the important findings here is the sign. You have heard about it in the module of uroradiology, which is known as the claw sign. The claw sign indicates that this lesion is originating from this structure, and this structure is uterus, and you got the claw sign, and meaning that this is a uterine fibroid. And this is one of the important signs to separate between an ovarian pathology and a uterine pathology, especially if this lesion is subserosal and you want to discriminate between adnexal lesion and the uterine lesion. Then the next case is a female patient with 12 years old with a big mass, and this two images after therapy. Okay, this is if you see a huge mass with fluid and fat signals as well as calcium, especially in a younger age, then you know that this is immature teratoma, and this is immature teratoma is a malignant one. But after therapy, there may be what is known as retroconversion phenomena, and it may turn as if it is a regular dermoid cyst or the benign form of this malignant tumor. Then huge mass with fat, calcium, and fluid and other soft tissues within the mass in a younger age may is suggestive of an immature teratoma, which is a malignant tumor, compared to the dermoid cyst, which is usually of benign nature. Next case is a female, 40 years old, with lower abdominal pain, and the ultrasound showed multiple cysts in the ovary. Multiple cysts in the pelvis. And this is a classic appearance of hydrosalpinx. You can easily appreciate the tubal configuration of the lesion on both sides, and this is obstructed tubes containing fluid, diagnostic of bilateral hydrosalpinx by MRI. Next case is actually I don't know the age of this patient, but you got a big mass in the pelvis, and these red rings indicate the presence of fat, And these lines indicate the presence of internal septations. And mucinous cystadenoma is part of the answer, and the fat is not a component of mucinous cystadenoma, but the fat is a component of dermoid cyst. And I recently know that both lesions can coexist in the same patient, the dermoid cyst and the cystadenoma. So if you see a huge mass with internal septation of cystic nature, this is mucinous cystadenoma. If you can see fat and sometimes calcium inside the lesion, and this is the combination of dermoid and cystadenoma. Next case is a female patient, 44 years old, with a history of breast cancer, and she is receiving tamoxifen. No, this is not hemorrhagic cysts. They are of high signal. There is some hemorrhage here, but they are of high signal in the T2, and they show some marginal post-contrast enhancement, but this is not uh, no, endometriosis should show the shading sign in the T2 weighted image, but this tamoxifen is known to induce what is known as ovarian hyperstimulation, resulting in the development of many cysts, which is exactly similar to the polycystic ovaries. Then tamoxifen ovarian hyperstimulation syndrome is rare, and is also rare in older females. Usually resolves with temporary discontinuation of tamoxifen. However, the recurrence of symptoms when resuming tamoxifen is better treated by bilateral salpingio-oophorectomy to enable adjuvant therapy. And this is one of the lines of treatment in such cases. Next case is a female patient with 62 years old with a big abdominal or pelvic mass. Okay, and if you look carefully here and you look for this is the uterus, then this lesion is not of uterine origin, and this is ovarian cancer, right? A big mass with cystic component and solid component, and you expected that this is malignant. And if the uterus is good, then this is an adnexal lesion. An adnexal lesion with a cystic and solid component is diagnostic of ovarian cancer. These images are sagittal coronal T2 and axial T2, axial T2, axial T1 post contrast. Yes, and this is fibroid with some internal degenerative changes. Fibroid should be jet black in the T2 weighted images, but the presence of internal areas of high signal in T2 indicates some degenerative changes. Next case is a patient, 25 years old, with dysmenorrhea and pelvic pain. This is T1 and this is T2. Um, Adenomyosis and endometriosis. Yes, this is the right answer. If you look to the uterus and you got marked enlargement of the junctional zone with multiple areas of bright signal in the T2 weighted images. If you look to the adnexal lesions, they are bright in the T1 and the characteristic shading in the T2 weighted images, which is pathognomonic of endometrioma, bilateral endometriosis, and adenomyosis in the uterus. Next case is hysterosalpingogram, and the arrow points to the pathology. Stricture of the tubal divertically, yes, but you know that this lesion is known as salpingitis ischica nodosa. Is characteristically present near the isthmus of the fallopian tube with multiple small diverticuli along the course of the tube. This is known as salpingitis ischica nodosa, and it can be bilateral and can be also unilateral, as in this case. Next is a female, let us say a child, 12 years old, with this mass in the pelvis. Yes, and this is characteristic of this germinoma, a big lesion in a young female, and the lesion is mostly solid. But you should remember that this germinoma can contain also cystic changes, but frequently it is solid and huge. This is the uterus, which is good, and this is the mass, which shows diffusion restriction. Next case is female, 15 years old, with bilateral lumbar and pelvic pain. Yes, hematocolpus is part of the lesion. If you look carefully here and you see another uterine cornea which is not involved by the hematocolpus, this is the uterine cornea corresponding to the hematocolpus, and this is another cornea. This is known as uterus didelphys with hematometria of the one of the components of the uterus didelphys. You all know that I am not so much experienced in the breast imaging, but I provide you with some straightforward cases, and also there should be a case in the exam, and this is by red 5, and this is breast cancer, as you can easily appreciate. The next is a big lesion in the pelvis. This is axial, and this is sagittal T2, and this is sagittal T1 post contrast fat set. Okay, and actually, this is not a dermoid cyst, it is of uterine origin. And this mass is, as you can see, is an aggressive mass, and it has the signal that is different from uterine fibroid, and the behavior of the mass is not similar to endometrial cancer. This lesion is invading the anterior abdominal wall and shows heterogeneous post-contrast enhancement. And I have mentioned, if you are confronted by lesion like this, think of uterine sarcoma and instead of thinking of aggressive endometrial cancer. Uterine sarcoma is a well-known pathology, and it can be mistaken for endometrial carcinoma if it is localized. But if it is large and invasive and extends into various directions, you should think of uterine sarcoma. Next case is a child with menstrual cramps, progressive pain in the hypogastric region. This is MRI of the abdomen, and this is MRI of the pelvis. Unicornate uterus with retrograde menstruation. في هي كاتبة OHMRVRA. أنا مش عارف, I don't know what is this abbreviation stands for. And the kidney is absent. Yes, the kidney is absent, and the uterus is didelphys. And you got a single cornea here and another one which is obstructed, leading to hematometrocolpus. This combination is known as Hurlin-Werner Wunderlich syndrome. This syndrome should include uterus didelphys. One of the cornea is obstructed, leading to hematometrocolpus, and on the same side of this hematometrocolpus, the kidney is not present. Then we have the Werner Wunderlich syndrome, composed of three main categories: uterus didelphys, blind hemivagina, and ipsilateral renal agenesis. And then you can see here two uterine cornea, blood in the vagina, and the abdominal image show that the kidney is present on one side and is not present on the opposite side. Next case is a female patient, 54 years old. And this is T1, and this is T2, this is diffusion, and this is T1 out of phase. You know that out of phase images are resulted to exclude or to prove the presence of microscopic fat within the lesion. Then the answers is the ovarian cancer. This is a solid lesion, mostly a solid lesion, and has a smooth edge and multiple internal cystic changes. And this out of phase image did not confirm the presence of fat inside the lesion, and this is also the contrast enhanced images showing in the early phase no enhancement, but in the late phase you got heterogeneous post-contrast enhancement. Actually, these are features of a relatively uncommon ovarian lesion, which is known as the thecoma. And because of its frequency in the literature, I suggested that you should know some words about this lesion. The ovarian thecoma is a benign ovarian tumor. It accounts for about 1% of ovarian lesions, and it is a functional lesion secreting estrogen, and commonly is present after menopause, and may present by vaginal bleeding similar to another tumor which is known as the granulosa cell tumor. But hyperestrogenism due to thecoma is less common compared to the granulosa cell tumor. Sometimes fibroma and the thecoma are combined together, and you got this tumor, which is also well known and is known as fibrothecoma. 20% of these lesions may be associated with concurrent endometrial cancer, and they are typically unilateral solid ovarian mass of low signal in T1 and T2 with variable pattern of both contrast enhanced. The solid ovarian lesions are many, as you know, and they include the ovarian fibroma, ovarian thecoma, ovarian fibrothecoma, the Krukenberg metastatic tumor, ovarian lymphoma, and the Brunner tumor. All these six lesions can appear as solid in the MR images, and this is another example of a lesion that is solid of adnexal origin, and you can see that the uterus is good, the urinary bladder is also good. Then you are not that you should not or you cannot diagnose this as a spot diagnosis, but you can put it in the differential diagnosis of solid adnexal masses. Then the next is a huge lesion in the pelvis, and actually you can see the uterus, you see the renal bladder. And what do you think of this lesion? Dermoids, you need to see fat inside, and the fat is not well appreciated except in the T1 and in the fat suppressed images. But the huge lesion with internal septation and different signals of each component is diagnostic of mucinous ovarian tumor. If the tumor contains a solid component, then you say that this is mucinous ovarian cyst adenocarcinoma. If the tumor does not contain a solid component, then this is mucinous cystadenoma. And this is a hysterosalpingogram. Yes, and this is a straightforward case of uterus didelphys, two separate uterine cornea. Each is cannulated by a separate cannula, and each cornea has its separate fallopian tube, and this is classic appearance of uterus didelphys. شكرا جزيلا.